Thank you, Kojo, and Charlie, I think, disappeared to go get his lab demo ready. Thank you very much, everyone, most of all for the residents and fellows to come out and spend some time, as well as the Seattle Science Foundation, Linda, and the great merch. Wanted to give a little bit of a different talk, so rather than talking about a technique, which you guys are really focused in on, wanted to talk a little bit higher level about robotics and spine surgery. Here are my disclosures. Before I go forward, I left this picture up for Dr. Chapman, of course, who's not here, but he will see it later on the video. How many of you are orthopedic residents or spine ortho fellows? Okay, how many are neurosurgery residents? Oh, we outnumber the ortho guys today. All right, how many of you in your programs routinely use navigation, some sort of 2D or 3D navigation for pedicle screws? Yes, actually less than half. How many of you use or have any experience with robotics in spine surgery? Oh, that's a great number. That's about a third or fourth. And how many of you use any minimally invasive techniques of any kind? Oh, that's really good. Okay, super. So I show this because Dr. Chapman is a self-deprecating guy and always talks about him being a dinosaur. I'm right with him. I'm one of the dinosaurs as well. But over time, I've become a dinosaur converted into a robo-doc or a robo-surgeon. And I hope someday that Dr. Chapman will also end up on that side of the slide. So the outline for today is really just want to introduce you to the topic of navigation and robotics and spine surgery, although a lot of you have had some experience. Talk about how that can translate into early success in your career as you think about your early career, not just training and finishing, but encourage you to kind of take this nugget, which was passed down to me by my father, who's a retired interventional radiologist. And when I finished neurosurgery residency, he said, "You don't know jack about neurosurgery until you start practicing neurosurgery for 5 to 10 years." And so the concept here is you're never too old or too good to stop learning. And so echoed by some of the other faculty, I learn as much probably as I deliver and teach with this course. So anyone know who Mr. Miyagi is? Right, okay. So there's gonna be some Mr. Miyagi pearls as we go through this talk. So a little bit about me, old school dinosaur neurosurgeon, trained in the 90s. Did not learn how to put pedicle screws in from my faculty. We learned that from the orthopedic spine faculty. And many of you may not know, but in the 1990s, there was a really raging philosophy against pedicle screw instrumentation. There were a lot of investigative reports in 2020 shows that showed it was bad, and surgeons that put in pedicle screws were bad and illegal and unlawful. But in those days, open spine surgery was the standard, and so I trained as an open spine surgeon, and a lumbar disc surgery patient stayed in the hospital for a couple of days. Uncomplicated, didn't get out of bed until day 1, walked on day 2, and might have gotten home on day 3. The only enabling technology in the 1990s for spine surgery was use of a microscope. Right, and the microscope's been around for a long time, but as neurosurgeons, we were comfortable using the microscope in the brain, so we easily adapted that to spine surgery. Well, spinal fusions back in the 90s was typically a posterior open lumbar interbody fusion, or the PLIF technique that was popularized by Dr. Cloward. The ALIF technique was just coming around with titanium cages and threaded bone dowels. But look at the typical hospitalization for a posterior lumbar fusion. It was 5 to 7 days, usually 7 to 10 days, Foley catheter for a couple of days, PCA pumps, didn't get out of bed for, again, a day or two. And that was the standard of care, and we had really, really good results. So, but things change, right? Technology evolves, techniques evolve, and hopefully we learn from our mistakes, learn from our successes, and become better surgeons. So in the 90s when I trained, we only had 2 goals for spine surgery: improve your pain and improve your neurological deficit or avoid a neurological deficit. That was it. We didn't talk about all these other things in yellow, which have evolved over the last couple of decades in understanding biomechanics, prehab, post-rehab, spine surgery, and trying to avoid some of the complications. And so now, I hope during your training, you'll not only just think about reducing pain and reducing a neurological deficit, but start thinking about these other goals as you're going into these cases that you're learning how to do the technique. We want to reduce the chances of revision surgery, meaning we want our first operation hopefully to be the best operation and the last operation, but we know that 10 to 20% are going to need a second operation, but maybe we can lower that down to 5 or 10%. We want to shorten hospitalizations, we want to shorten the recovery, and we want to reduce costs. And I think that's something that I did not learn in my training and have had to learn as originally a private practice surgeon, and I hope you'll think about resource utilization cost as you go about your training. So the goals of surgery not only are reducing pain and improving the outcomes, but we want to reduce the morbidity and mortality. And so I've learned a lot over the decades about using minimally invasive techniques, adding navigation, and ultimately robotics. And so that's grouped into that enabling technology group of things that we can start to employ and add to our armamentarium. I'm not going to talk anything about endoscopy. I think I'm a little too old to learn that technique. I think there's a steep learning curve for me, but I did want to introduce you to robotics. So robotics really goes very nicely with the concept and the philosophy of a minimally invasive technique. And so a minimally invasive technique is not about the incision or the retractor or the perch screw. It's a surgical philosophy. And we can take that philosophy and we can adapt it to virtually every operation we do in the spine, whether it's cervical, thoracic, lumbar. Doesn't matter the approach. It can be anterior, lateral, posterior. We should be able to execute those operations and use a minimally invasive philosophy. So the benefits of MIS when I started doing this in 2003 were not very obvious, and there was no documentation or literature to prove that, but we now have 20 years of history and literature to suggest benefits of minimally invasive spine surgery. And you don't even have to look at that list on the left, but just look at this MRI on the right. This is an MRI scan of a friend of mine who's now 58, but he was a F-16 pilot. And when he was in college, he had to have a lumbar laminectomy and discectomy for a disc herniation at L4-5. And if you look at his MRI scan from an open discectomy, microscopic, he has tremendous scar tissue and replacement of fat in his paraspinal rector muscle group. This guy is a triathlete. I don't know how he can be a triathlete after that, but you can imagine your 60 and 70 and 80-year-old patients who have potentially open spine surgery, and you've just torched the erector spinae to do a posterior operation. And so I think if you start looking at your postoperative MRI scans and understanding how MIS can help, and then you can build upon all those techniques to get ultimately a better outcome for our patients. So surgical navigation for me, I was an early adopter in about 2004, and you know the benefits of navigation because most of you are using it. So it improves our accuracy of screws, it improves the efficiency of surgery, it reduces the radiation, but most importantly, there's a growing evidence of cost effectiveness. If we can shorten our hospitalization by 1 day, 2 days, 3 days, we can substantially reduce the cost utilization for our spine surgery patients. And the story I like to tell that my dad used to tell me is, Rick, there's not going to be enough Medicare for you when you become Medicare age because we're overutilizing our resources and spending too much money on things that we shouldn't be spending too much money on in healthcare. So navigation, as most of you know, has shown to be cost-effective because we're better at placing screws, and if we're better at placing screws, we're reducing a bad screw, malpositioned screw, neurological deficit, and adjacent level disease. And you can look at all the literature, doesn't matter what navigation device you use, we get to the high 90% accuracy in placing pedicle screws. If you look to the far left, that's open, freehand fluoro. If you're honest and you look at the literature, the accuracy is around 75 to 80%. Now, I was an open spine surgeon, and I would tell you I was probably better than 75 to 80%, but in actuality, the literature suggests that's as good as we were back in the 90s. So revision surgery is costly, right? So we may think it's, well, let's just go back in, take out that screw, re-drill a hole, put in a new screw. The average resource utilization and cost for revision surgery is $25,000. That's old number. That number's probably in the $40,000 to $50,000 range now. So yeah, it's just a quick little revision, but it's an extended length of stay, it's more hardware, and et cetera. So how about robotics? I adopted robotics and added it in 2018 after being very, very gun shy early before 2018. And I was intrigued with robotics and the advanced surgical planning. So it's using a computer and my laptop to comprehensively plan my lumbar fusion, not just putting in the screws, and it sort of deserved appropriate criticism early on that with robots were very expensive drill guides, and they were. But over this 5 to 7 years, there's been a rapid escalation in the technology, both software and hardware. So now I use the computer to plan my incisions. I use the computer to plan my pedicle screws and individualize every pedicle screw. I can plan my inner body correction with static or expandable cages. I can plan my decortication for facet fusion. I can even now plan my laminectomy and facetectomy using the computer and some special hardware. So again, robotics takes us to another level of accuracy with pedicle screw placement, but more importantly, precision, standardization of the procedure, and in some cases, reducing the length of the procedure. So with most robots, there's a three-pronged goal, and that is the predictability of planning, the precision of the robot, and ultimately seeing what we're doing by having virtual and navigation pictures as we're placing the screws, oftentimes in an MIS or mini-open technique, or even in the open technique. Those of you that are early users of navigation understand the confidence you feel when you're placing in pedicle screws and you have navigation to guide you. So most robots are a little bit different. This particular robot uses a software algorithm called segmental registration, and that means that the robot is sort of looking for vertebral bodies independent of each other, so that if you have changes in position of the L4-5 segment during the operation or with positioning, the robot can find L4 and match it to L4 on the preoperative X-rays or CT, find L5 independently of L4. And with that type of registration technique, we find that it's incredibly rare to have some sort of mishap with registration and having to bail out on the registration. How many of you have done navigation and ultimately navigation has a problem and you have to bail on the navigation? Right, still happens. With this particular robot, it's a fully independent robot that had navigation embedded into it. So if the navigation goes out during the surgery, you can still put in the accurate screws with the robot, even without navigation. So here's a short video. It's sped up a little bit, but I like to use the CT to fluoro workflow, which is getting a preoperative CT on the patient weeks or months in advance. That protocol is uploaded and those images are uploaded to my computer workstation or uploaded to the robot, and there'll be a demo this afternoon and you'll all be able to put in screws tomorrow with the robot. I can individually plan my screws for the insertion point, the trajectory, the angle, the diameter, and the length. How many of you only walk in thinking about diameter and length? Right, diameter and length is the most important, but if we can individualize every pedicle, we might find that the left L5 pedicle screw needs to be a little bit more convergent than the right L5 pedicle screw, or vice versa. We can also use the computer software to plan multiple screws so that we can line up for instance, in a PERC screw case or a multi-level deformity or trauma case, we can line up the rods and the screws in such a way that it makes it much easier at the end of the case to drop the rod. How many of us do all this hard work and then we just want to drop the rod, place the set screws and start closing, and all of a sudden you're effing around for another hour to get the rod bent right and to hit the pedicle screw right, and then tulips bent, and then you got to take a screw out and put another one in. You might even put cross connectors, but with software planning and predictive modeling, you can eliminate all of that. This software also allows us to plan inner body cages, and we can simulate our correction of the spine with the patient imaging studies prior to the operation. We can simulate the correction for a short segment or even a long segment. Sorry, my videos are kind of freezing here. And again, improve our ability to plan an operation and then go into the operating room and just simply be able to execute the operation. On the right side, you'll see the software can allow us to line up our screws to drop a rod. And so we can do multi-level cases, do patient-specific rods, just drop the rod in and adjust our screw trajectory to match the rod. Again, all to improve the outcome, improve the safety, and reduce the complication profile for instrumented fusions. Oh, now I got too many videos going on at the same time. There is a software module in this particular robot that allows us to do planning preoperatively for deformity. So we can take our 36-inch Goli x-rays, upload them into the robot. Preoperatively, we can plan where we're going to do our deformity correction, where we're going to put our inner bodies, where we're going to put our hyperlordotic inner bodies, and then we plan the correction on the computer. The computer and the operator can then generate the spinal pelvic measurements, both preoperatively and on the virtual plan. You can adjust your surgical technique according to the spinal pelvic measurements, and then walk into the operating room and execute that operation. So we're taking the power of predictive modeling and some AI and be able to enhance our ability to perform instrumented thoracolumbar fusions. For most of the robots, there's 2 workflows to do this. The one workflow I like the best is to do a preoperative CT scan, again, weeks, days, or months prior to the surgery. That scan is uploaded in the computer, and I can plan these operations weeks or months in advance, or I can plan it in the morning during the anesthetic phase of the surgery when they're going to sleep and before positioning. That CT to fluoro workflow then is matched and registered with 2 fluoro shots in the operating room, and that's where that computer algorithm matches all of the imaging. The benefit of that is I can do all of my planning of the surgery before the surgery, walk in, do the shots to register, execute the surgery. The other option is to do what's called scan and plan, and that would be avoiding a preoperative CT scan, but if you have an O-arm or some sort of 3D CT device, do your image acquisition while the patient's in the prone position, then upload those images to the robot and do your planning, and then perform and execute the operation. So just a different style. If you work in a place where your O-arm crew is really fast and efficient, that works great for a lot of surgeons. If you're in a place where they're not so efficient, sometimes the CT to fluoro workflow is better for the surgeon and better for the patient. So the key here is to just introduce you to robotics and understand that robotics is just another enabling technology like navigation, like MIS, that you should be able to apply to whatever technique you're doing the operation for. And so I would argue, I'm not here to tell you that a TLIF is the greatest operation, because most of the time it is a great operation, but the idea is you can apply these enabling technologies to whichever operation you find that patient needs. An MIS or an open, a TLIF, a PLIF, any of the lateral surgeries, we can incorporate navigation and robotic technology, even anterior operations. If you have to do a 360 with an anterior lumbar interbody fusion, flip the patient over for posterior instrumented fusion, great role for robotics and navigation. And whether you're a pediatric deformity surgeon, adult, or mostly degen, trauma guy like me, you can apply these technologies. So how many of you are training or do put in instrumentation first and your decompression last? Yeah, how many of you decompression first and instrumentation last? Yeah, that's been a real change. So in our training early on as neurosurgeons, we were taught to do the decompression first. That's the most important, or should be the most important, and then we instrument at the end. The good news is with these enabling technologies, you use the enabling technology that fits your workflow. So whether or not you want to put your instrumentation in first, there's a workflow for using the robot. If for whatever reason you put in the instrumentation last, there's a workflow to use the robot. So these technologies should not make you change your workflow. And as young residents, you're learning your workflow, right? And you might change your workflow over the years, but don't let these technologies force you into a workflow that you're not comfortable with. Okay, so adding these enabling technologies, especially robotics for me in 2019, allowed me, going into COVID, to look at the opportunity of doing outpatient instrumented lumbar fusion surgery. And so some of you may or may not remember COVID. We'd like to forget it. that we had in Tucson significant gaps in our ability to do inpatient elective spine surgery. For 6 weeks in March through May, we couldn't do any surgery unless it was cauda equina syndrome or a foot drop. Just couldn't do it. They wouldn't let us do it. Then we had times where we could do outpatient surgeries or minimal 4-hour stay before we could admit patients. But I had weeks of patients who were scheduled for lumbar fusions, and they're, can you do my surgery? Please do my surgery. So I thought there was an opportunity to perhaps carefully select patients and do outpatient lumbar fusions in the hospital. I didn't at that time have opportunity to work in an ASC. So took these concept MIS techniques, navigation, robotic-assisted screws, extended recovery after surgery, concepts of pre-op medication, intra-op medication, and post-op medication, and we were able to very early on successfully convert about 60% of our what was previously an admitted elective inpatient lumbar fusion and convert them to outpatient surgery. Initially keeping them in the recovery room for 4 hours, and then 3 hours, and then 2 hours, and now 80% of my lumbar fusions are done on an outpatient basis, and they go home within 2 hours. That you can see we did a really short study of some of the first patients we did outpatient. They're mostly T-lifts, 1 and 2 levels, including a couple of 3 levels. The surgery time isn't, terrible, and in fact, that's probably the most important indicator of getting a patient out of the hospital is your surgery time. So the results were just a handful of patients had issues with urinary retention. That had nothing to do with the surgical technique. That's on me. I like to give patients epidural morphine at the end of the operation to help with pain control. And for men over the age of about 65, some of whom already have some BPH issues or urinary retention issues, can get urinary retention after that. And so that's taught me to sort of sub-select those patients, and I don't do epidural morphine in older male patients. We had 1 or 2 patients initially that we had kept them overnight for pain control, but otherwise the most important thing was highly satisfied patients. Patients will come to you and come to us and say, I don't want a fusion, here's why. And they've got a lot of great reasons why they don't want a lumbar fusion. But when you can educate patients about maybe doing this in an outpatient basis or a short stay, 23-hour OBS, they love you. They come back, they tell all your friends and family about you, and then you get the friends and family to come see you. So the newest application of robotics is the most exciting, and it was first published last year by Chris Good's group, and that is using the robot to do bone removal. So we've talked about using the robot for placing screws and planning, but not bone removal. And so now we have the ability with this particular robot to do bone removal, which leads us to do a facet fusion, right? And potentially bone removal to do the decompression. So both the laminectomy and the facetectomy. And I'm going to show her this short video because it shows it better than I can explain, but using the computer, using the planning, and using the robotic guidance system, we can use a different drill bit to decorticate the facet joint, whether it's an open or an MIS technique, and then backfill that decortication defect with bone graft. And so now we've been able to accomplish a robotic fusion, not just robotic placement of the instrumentation. And here you can see the video planning the decortication defect, again, planning with the screws and the inner body, verifying the accuracy of where we're going to do this decortication, and then doing the fusion in the operating room. And you all get to see this in the lab tomorrow for sure, and then even during the demo a little bit later this afternoon. So here's sending the arm to the trajectory to do the decortication part, making a stab incision or in an open incision, going down with the navigated dilator and cannula to the site of the facet, confirming it with the navigation, and then drilling the hole with this special drill bit. This drill bit is designed to pull the bone graft or the facet bone out rather than push it forward. And then once we drill that hole, we can then backfill it with bone graft. This software and hardware was just released late last year, 2023, so we're getting early experience with it. It seems to be, again, very accurate, efficient, and precision way to do this portion of the operation. Here's I call it the caulk gun. My wife won't let me use a caulk gun at home, so I have to come to the hospital in the OR and use a caulk gun to deliver my bone graft into the facet joint. She says I always put too much stuff. And so here's delivering the bone graft into that facet defect to create the fusion. So the most exciting thing that we've started in the last couple of months is taking that technology and using robotic precision, computer navigation to do the facetectomy and do the laminectomy. And that's really exciting, probably done about 10 to 15 cases now. So on this spine model, there's your facetectomy that you do, however you do it. Open, MIS, perc, osteotome, drill, burr. There's the hemilaminectomy on the ipsilateral side of your TLIF. There's the contralateral decompression, again, whether you do it open or MIS. And on the axial view, if you look at those boxes, I can now use the computer to plan those pathways and trajectories to do the decompression. This is a case we just did. Actually, I think Ryan did this case with me a couple of weeks ago. This is down a 22 millimeter tube, hard to see a little bit of muscle there, but the point is I wanted to show you the anatomy. There's the L5 pedicle on the right. That's the midline. You can see the drill defect there from the facetectomy. And then a close-up view, there's the pedicle, there's the midline. That's residual lamina and facet laterally on the right side, a little bit of lamina superiorly, a little bit of the inferior facet of L4, but you can see in about 4 trajectories or 4 passes of that decortication tool, I've done my entire decompression, and then I can get to the work of the inner body. That's roughly the decompression I do for an MIS TLIF, which is both ipsilateral decompression and contralateral decompression. That's after that's all been done. There's the thecal sac and the cage in the inner body space. And again, nice wide decompression using robotic techniques. So real quick, L4-5 spondylolisthesis, I try to learn from the deformity surgeons about balance, PIL mismatch. I want to improve the SVA with this plan, even for a 2-level, with a mobile spondy and stenosis at L4-5 and a mobile spondy at L5-S1. But now I can use the robot to plan the decompression. So at L4-5, I'm going to plan about 6 or 7 trajectories on a left-sided approach. But at L5-S1, I don't need to decompress the canal. I just need to remove the facet to give me access to the inner body fusion. So what that looks like top left is L4-5, doing an ipsilateral and contralateral decompression and the facet fusion on the contralateral side. And at L5-S1, just doing a facetectomy, but an L5-S1 fusion on the right side. Again, all planned ahead of time, executed by the robot with a 2-level TLIF technique. We can take that technology and go to the trauma indication. So here's an L2 burst fracture, and I can do this with an MIS percutaneous robotically executed fusion from T12 to L4. Again, using the planning for the screws, but also the facet fusion, and get an excellent result. This operation is about an hour and a half MIS technique in a patient with multiple other trauma injuries, and we can get them up. This is a case we did last week with a traumatic burst fracture from a car accident, sort of a weird chance fracture, a big retropulse fragment in the canal. He presented with L5 complete foot drop and an L5 radiculopathy. We did an MIS technique, robotic assisted. Here's through a tubular retractor, 18 millimeter. Did a decompression and took a bone tamp onto the back of that piece of bone, shoved it forward, and then did a posterior robotic facet fusion. The pictures don't do it justice. The top left is retracting the L5 nerve root, and that's the big piece of bone retropulsed posteriorly. The top right picture is the bone tamp. The bottom left picture is that bone has been pushed forward, and then the final picture is the thecal sac. We go ahead and instrument him and do a contralateral fusion, and you can see impacting the bone forward. His pain resolved within a day, and his foot drop resolved by day 2. So we can now use the robot to do every part of the operation, just like the Teslas. 90% of a Tesla is built by robots. Less than 10% a human even touches it. So it is now the coolest robot in spine surgery. And then this is a video again for Dr. Chapman, who's not here, but ultimately the robots do take over the dinosaurs. And in this particular video, they work together at the end. And with that, I'll stop. I'm sorry that the audio isn't there. I'll stop. I think I've gone a little bit over time. I apologize, Kojo.
You're on.
Okay. Any questions? Kojo, is it okay to take questions now?
Yes.
Okay.
Go ahead.
I'm David McCarthy. You previously, how often do you have these goals for spinal pelvic parameters and then you fail to meet them after scanning X-rays?
Yeah, great question. So again, I'm predominantly a degen surgeon. I've learned over the years to apply the technologies and techniques and goals from the deformity surgeons. We're actually looking at my series of 1 and 2 level degen patients, and so far we have about a 90% correlation with 1-year follow-up of standing X-rays with those spinal pelvic parameters compared to our plan before surgery, which I think is way better than I would have anticipated. And that's with MIS technique through a tubular retractor. So there's not a lot of bone removal other than a facet resection, expandable cages, and then computerized planning with patient-specific rods. So very, very happy that to sort of support the idea that degen surgeons can actually do deformity surgery, or we actually respect those parameters even when we're doing 1 and 2 level T-lifts.
Hey, Dr. Chua, thank you for the talk. It was great. Josh Lux, University of Maryland. I have a question about, you mentioned movement to ASCs. I was curious if you're starting to use robotics in that setting.
Yeah, so I have not. I have limited access to ASCs as a University of Arizona surgeon. The biggest issue of moving robotics into the ASCs is the cost. So any robot on the market is somewhere between $1 million and $1.5 million. And if you're an owner of an ASC, you're not footing that bill. Now, the companies have very creative ways to help you finance getting high expensive technologies, high capital technologies in the ASC, and you sort of work with the ownership group or the leadership to do that. There are some non-robotic navigated systems, though, that are much less expensive and are probably specifically great capital type investments for the ASC market.
Hey, Hussein from University of Toronto. I was just curious if there's any current applications or anything in the pipeline for the cervical spine for robotics?
There is. So robots can be applied to the cervical spine. Most of the robots are cleared for indications in the cervical spine. I don't use the robot in the cervical spine, as most robot surgeons don't use it for the cervical spine, because we haven't been able to control the movement of the spine in the prone position. And so we need pretty significant fixation without movement of the patient. So, you know, things like C1-2 might be a good indication for robotics because of the accuracy and the efficiency and the precision. But, you know, any first and second year residents here? Third year residents, y'all ought to be able to put in a laminar mass screw, you know, with fluoro, 1 shot, 2 shots. So I think we're going to find applications for cervical spine, but it's really not widespread. And Dr. Skaggs may have a different opinion about cervical for robotics, but we're not quite there yet.
All right.
Thank you.
Thank you.